Welcome to Pediatric Sedation and Anesthesia. I'm Gary Badger, the Professor of Pediatric Dentistry at the University of Texas, School of Dentistry in Houston. And today we're going to be talking about the Putting It All Together, Module 15.
I received no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. Section Overview. This section presents information to create an understanding of the continuum of sedation through which the dentist can make appropriate choices of pharmacologic agents that can be safely and effectively used for the various pediatric dental sedation procedures. This course is part of a 16-hour comprehensive program designed to meet the requirements of Texas State Board of Dental Examiners Rules 110.17. Sedation anesthesia of pediatric patients.
Welcome to the Pediatric Sedation and Anesthesia course. We're going to be talking about the last module, which is putting it all together, and that means getting all the information we've talked about over this time together to make a consolidated approach to treating patients. The importance of doing this is to make sure that everything is working together smoothly and we have a final concept on how this should look. Images used in this presentation are taken from non-copyrighted sources in electronic media and attributed as much as possible. The de-identified images are provided as an educational resource to illustrate techniques and procedures for clarity. Objectives. The candidate should be able to establish a protocol for safe sedation, safely administer level 3 sedation, and understand the principles for prevention and rescue. Principles of sedation. A practitioner trained to handle any complication associated with sedation. Accurate and careful patient evaluation and selection. Thorough knowledge of selected medications and maximum dosages. Required informed consent from the guardian, and a well-equipped office. Backup emergency service. Pre, intra, post-operative written documentation. Maximum recommended dose for local anesthesia should be calculated by weight and not exceeded. Immobilization devices such as the papoose board should not interfere with adequate ventilation. Return the patient to a physiologic state in which safe discharge is possible as determined by recognized criteria. The physiology of sedation. Respiratory compromise and sequelae. Children have a less well-developed respiratory system and lower functional reserve compared to adults. Children tolerate hypercarbia to a greater degree than adults. Hypercarbia may trigger the onset of cardiac arrhythmias. Lower functional reserve means a greater post-expiration volume of carbon dioxide. Anatomical differences. Increased airway resistance. Friction of air passing through the respiratory system. Children have a greater resistance than adults. When airflow is laminar, the flow is greater than when it is turbulent. Crying or reduction in diameters of airways, such as asthma, create greater resistance exponentially. Glottis, or vocal cords, is more anterior and cephalad. Narrowest portion of the upper airway is at level of the cricoid cartilage, below the vocal cords. A relatively larger tongue and epiglottis, a larger head-to-body ratio. The mandible is less developed. Potential for significant lymphoid tissue obstructing the nasopharynx, the oropharynx, and the laryngopharynx. Patient selection. Traditional behavioral guidance techniques have been unsuccessful. Patients in ASA 1 or has medical condition that is well controlled, ASA 2. Patient below the age of reason, pre or uncooperative. Extent of treatment, ultimately determined by amount of local anesthesia allowed by weight. Needle phobic, excessively fearful older children. Older children with poor experiences or coping abilities. Distance traveled, even for patients without behavioral problems. History. Prematurity leads to less surface area for qualitative gas exchange. Poor qualitative and quantitative gas exchange occurs with prematurity. Increased incidence of early life intubation. Altered neural reflex pathways increases the gag reflex. Potentially at greater risk for laryngospasm. Hospitalization and ventilator use. Medical history. Allergies, asthma, croup must be considered. The atopic triad of asthma, eczema, and food allergy may suggest IgE hyperresponder caution. Current meds, including over-the-counter, may include depressants and herbal supplements. Diseases, cardiovascular, central nervous system, pulmonary, liver, kidney, pregnancy status, malignant hyperthermia risk, sleep apnea, snoring, suggest tonsils or airway problem, previous sedation, general anesthesia, hospitalization, and family history of diseases. The physical assessment. The general physical condition, the gait, wheelchair, coordination, what is their general physical condition? The gait may indicate an abnormal disease or developmental delay. Wheelchair on a developmentally delayed, perhaps hearing impaired or visual impairment or inadequate cognitive operation and coordination of reflexes and ability to perform. Vital signs, heart rate, regular rate and rhythm, respiratory rate, blood pressure. Vital signs of age, weight, and height gives us an idea about obesity and overweight. Airway, tonsils, enlarged tonsils determined by the Brodsky scale. The neck, is it mobile? Is it non-mobile? Has the neck been fused? Is there atlantoaxial instability? The nose, is it clear? Is it free of congestion? Is chronic bleeding occurring there? Is there stenosis occurring in the airway passage to limit the amount of ventilation that can occur? The tongue, does it have relative macroglossia? Does it provide the limitations that come with a malfacial occlusion? Must not be any potential for airway obstacle. Is the patient a mouth breather? Do they have nasal speech? Is there a submucous cleft with this patient that hasn't been repaired? Does a patient have difficulty in exchanging air and it ends up being a mouth breather? The C-spine precautions, noted particularly with Down syndrome and Arnold-Chiari malformation. Midface hypoplasia may be suggestive of existing airway comorbidities, such as stenosis. Risk assessment, ASA status 3 and 4 are contraindicated for in-office procedural sedation. Obesity, per the CDC, use percentile for ages 2 to 19 years of age. And the patient's communication ability. Is English their first language? Are they having receptive language difficulties. These are all essential to understand in the physical assessment prior to sedation. The pre-sedation preparation is really important. And in face of sedation impending, it is a risky procedure for our patients. It's important to be thinking preventively of the things that we do know we can do something about, of the dosages that we do know about. We can alter those in a way that's compatible with adequate sedation, yet less risky. These are features of understanding the pre-sedation preparation to limit our risk exposure as much as possible. And once that is determined, to receive informed consent in writing and verbal, with witnesses signing the consent forms so that we know that we have a legal authorized individual caring for that child. Procedures, risks, alternatives, and no treatment. In the consent form, it's important for us to give all explanations of expected complications that may occur with regards to the procedures that are planned. The risks are associated with medical conditions that may arise while we are working with the patient, or risk situations that don't appear under normal everyday activities arises when the sedation agents are applied to this patient. What if we don't do any treatment on this patient? That is one alternative. What if we do part of what is needed? What if we start with an urgent, emergent condition and just do that and take care of it, particularly with younger children who have not reached the age of 3 and would be an increased risk for procedures over 3 hours in the operating room. And finally, no treatment. Is it a recommendation that the parents will follow, or is it a recommendation that they do not wish to pursue? And under no treatment, it's important to have consent forms signed for that reason. Pre-sedation instructions must be verbal, written, dietary guidance, expectations of sedation on behavior, what will happen once the sedation agents are rendered to the patient, what will be the outcome of the sedation activities on the patient, and is that something that will prove to be hazardous to the patient's behavior when we're working? For example, paradoxical reactions to medications that occur spontaneously without knowledge and without assurance that it's going to happen every time and maybe just that one time. Parents need to understand that. It's a risk that's commonly taken, and all of this information must be expressed to the parents so that they can be ready for whatever eventuality occurs in the sedation episode. Intraoperatively, during sedation, it's important to understand how the child may respond to procedures, how painful or uncomfortable the procedures might be. Does the child have any coping skills? We know they'll be sedated. Will they become more alert when these painful procedures occur? And all we have at our beck and call is the utilization of local anesthetic that will numb up the patient's region where we intend to do our work, and hope that the sedation level that we have selected for the child will be suitable for the type of procedures that we're about to encounter. Postoperatively, once we are finished, it's important for us to realize that drugs tend to linger when they are given to children, and because of the metabolism of those drugs and knowing what the metabolism of those drugs have, these metabolites which may have actions of their own, it's important for us to know that, to be able to predict what behavior might occur postoperatively, and also to guide the parents in good postoperative observations so that nothing will happen to the patient once they have recovered in our office and left the building. The guardian and others, the driver for example, must accompany the patient to safely deliver the patient back to where they live while they are recovering from their sedation episode. The diet. Will the patient follow NPO guidelines? We know that it's 2 hours, up to 2 hours prior, it's clear liquids only. If it's 4 hours prior for breast milk, 6 hours prior for formula or non-human milk, and 6 hours prior for a light meal. It's up to us to decide if what was consumed is considered a light meal. And in the preoperative instructions, it's important to guide the parents to what exactly we mean by a light meal. Oftentimes, children will retrieve nutrition on their own without telling the parents about it, even though the parents may have expressed to them that the limited foods that they are allowed to take need to be followed. So diet is important to follow. And if there's any violation of the NPO guidelines, it's up to us to ensure that no sedation is risked for that patient during that time. On the day of assessment, it's really important to review the medical history. Oftentimes when we are faced with doing sedations, there's a large and long delay between the time we have diagnosed the patient and their condition and the treatment plan that was made and the time we're able to deliver care. And over that time frame, it's possible that children could be involved in some medical issues, receiving the flu or some childhood illnesses or some pneumonia, or ones who are young enough not to have been diagnosed with their medical condition. Suspicions were aroused, but nothing was really made clear. And once that occurs in the medical history, on the day of assessment they come, we review the medical history and find that they may have a diagnosed condition that they didn't have the previous time that we evaluated them, and therefore it's impossible for us to continue on with the sedation for that day. Any informed consent comes to legal guardians and parents and legal parents and court-appointed custodians. It's important for us to understand that when we are treating children, we need informed consent signed and understood by the person who's bringing them in that is a legal custodial guardian of the child. Reviewing medical consultations. If we, at the appointment time, sent the patient for medical consultation to determine a medical condition that might affect sedation results, needs to be investigated. We need to have that information. Oftentimes, the medical community does not meet the deadlines that we seek, and therefore the patient comes indicating that they tried to get an appointment but could not and did not realize how important that information was to us, and therefore we must cancel our sedations until that consultation is obtained. The NPO status, or taking over-the-counter medications, or those prescription medications, it's important for us to know exactly what the patient has taken, what they are presently taking. Is it a change from what we prescribed for them before? Are the medications that they've been prescribed or taking, are they working to treat the result of whatever illness that they have come up with? So on the day of assessment, we need to make sure that we are clear on what medications have been taken, when they were taking, and will they interfere with the sedation drugs that we're using. And finally, to review the sleep status. It's becoming more and more apparent that obstructive sleep apnea affects the treatment of the child and what medications they may be taking to improve that obstructive sleep apnea, and that the consequence of doing that may hinder or make ineffectual the organs which metabolize those drugs or sensitize them to sedation drugs that we plan to use, and we need to consider reducing the drug dosage that we commonly give. So on the day of assessment, it becomes the reality that sedation will occur provided we understand all the limitations that the day of assessment review provides for us. Medications for chronic conditions follow the NPO guidelines. Make sure that the bladder is emptied prior to giving the medications. Take baseline vitals to reassure ourselves that they fall within the range that we expect for a healthy child that's coming to our office for that day. What are reasons to cancel or defer sedation appointments? Active or recent respiratory infections with nasal discharge. Nasal discharge, the character has to be either it's watery or it's much more mucus, and the color. They have large tonsils. Are the tonsils healthy, or do they have an infection that's going on? We need to know what these elements are that affect the respiration, because that is the primary organ system that allows us to keep this patient safe during the time that they're sedated. NPO violations cannot be violated, and if there is one, we determine there is one, and oftentimes it just takes a question to the child rather than the parent. Did you have anything to eat this morning? What was it? How much did you take? When was it? We can find out that children have been violating the NPO order in spite of our best efforts. Fever or cough, is that developing? Fever was an elevated temperature greater than 104, and we know that if that is observed, we don't want to work in the face of fighting the patient's metabolism. Is there a cough? Is it intermittent? Is it constant? It could signal the beginnings of some asthmatic or cold or something that interferes with the respiratory system that we don't want when we're giving sedative drugs that will obtund much of the normal activity of that organ system. Is there recent head trauma? Did the child fall off a bicycle? Did they not have their helmet on? Did the trauma cause them to lose consciousness? How recently was that? So these are important features. If we don't know the answers to those questions, to cancel or defer sedation appointments. What is recent change of note in the medical history requiring a consultation? Perhaps it's this same head trauma that occurred, and they were unconscious and taken to the ER, and they were diagnosed with a concussion. And if we don't know about that, and it's not a medical history that the parent is accustomed to relating, then it may be overlooked. So it's important for us to rule out all these eventualities in the reasons to sedate children. Local anesthesia. Following guidelines of 4.4 milligrams per kilogram is the record of maximum dose calculated for local anesthetic use. We don't want to exceed that, and even though some newer local anesthetics are recommending a higher dosage level, I think it's fine for us to be able to utilize this lower maximum dosage record and ensure that all our patients are being treated under the same conditions. If moderate sedation, then we need to reduce the dose to well below the maximum recommended dosage to reduce potentiation for respiratory depression. It's important for us to be flexible enough and knowledgeable enough to be able to offer sedation medication, but also to consider local anesthetics, the application of topical anesthetics, and any other medications that may be on board before we give the drugs and add to a situation that may not be a qualitative move for us. The use of epinephrine, precautions for prolonged anesthesia, and lip or cheek trauma must be discussed with the parents so that epinephrine precautions for prolonged anesthesia is an element we can count on, yet be within the safe drug limits that will keep that child from having an adverse sedation event. We need to ensure that the local anesthetic is not aspirated. When we do our aspiration, that we have the local anesthetic purely under control, and we don't inadvertently inject into a vascular network that may cause some significant problems for this patient. Is there an overdose? Is there intravascular injection? If so, we need to know that an excessive dosage has been delivered to the patient and that we want to keep things under control, and not be worried about the reaction to local anesthetics that the body goes through. Because the overdoses will affect the CNS system, causing excitement initially, some stimulation. It's followed by depression, seizures, disorientation, and loss of consciousness. And we know that the limiting factor for administration of local anesthetic is provided by the weight of the patient. And if we have the patient who is overweight, we should be prescribing our medications and injecting our medications to compensate for this obesity or overweight, not on that weight, but on a lean body mass that we would expect for that typically aged patient. When the cardiovascular system becomes depressed, it has decreased contractility, lowering blood pressure, cardiac output, cardiovascular collapse. This is a preoperative sedation checklist. Every office that does sedation must have a preoperative sedation checklist of their own. As you look at this list, there are a number of things that ask us to check on to make sure that we know exactly what's happening with the patient. Once you go through this list, or the list that you provide or develop, it's important to know what ASA status that your patient has. What is the Mallampati score that you have for this patient? Does the patient have significant caries? Is their medical history been reviewed? Do they have other aspects, allergies reviewed, surgical history, the anesthesia history, if someone in the family has had a poor anesthesia result for general anesthesia? Is there a family anesthesia history? If so, how did it go? The caries, medication review, the medical consults are reviewed, the last meal that the patient had, the last menstrual period that the patient may have. So it may be that we have this preoperative checklist to ensure that we have not forgotten anything in the preparation for this patient. Once that is determined, we can have this sedation checklist signed and be a part of the dental record. The pre-procedure review includes a medical history. Has that been reviewed? Allergies reviewed or updated, or exacerbations, surgical history that's been reviewed, and have they had surgery before? Were they in the hospital? How long did it go? Did they have complications? Were they admitted to the hospital after the surgery for anesthesia issues? What is the anesthesia history? What were the elements that were used? And if you don't have that information, it's good to contact the hospital and get a copy of the medical record giving the patient's name and date of the treatment that was done. The family history is reviewed. Are there any congenital issues that need to be involved, or genetic consequences of patients' parents that might be contributing to this evaluation? Current medications, are they new? Are they updated? Patients who have ADHD or behavioral control medications, are they on a summer holiday? What was the medications that they were taking? What will they be taking when they resume school? And looking at the medical consults and it was reviewed. The pre-procedure examination tells us the ASA status, what's the Mallampati score, predicts the ease of endotracheal intubation, the Brodsky score, which is 0 for no tonsils visible, 1, they're barely visible, 2, the tonsils are not beyond the pillars, 3, it's up to 75% of the oropharyngeal airway is taken up by tonsils, and 4 is more than 75% takes up the oropharyngeal airway. Auscultation. Auscultation is a tool we can use for pulmonary investigations and evaluations. It's a brief assessment of the inhalation and expiration activity of the patient. Noises that are present indicate airway complexities that must be addressed. Cardiac auscultation uses the diaphragm for high-pitched sounds and the bell for low-pitched sounds. So we want to listen for the pitch and the timing in the cardiac auscultation. The pre-procedure timeout. The patient's identified, the planned procedure is verified, the equipment is checked, the consent is signed, the patient's escort is waiting, and special considerations, the signature of the attending. In the review of many medical records, it's apparent that doctors do not pay attention to signing the treatment plan and the authorization to take the patient to the operating room. So it's important that we monitor ourselves and make sure that we provide a legible signature so that we can easily be identified, and also a witness's signature so they will verify your signature. It's important to do that in a pre-procedure timeout. What about pharmacology? We know we use multiple agents to help us sedate children and sedate them carefully and with thoughts about what conditions might develop from the agents that we are adding. We need to know the dose, how much we're given, when the onset is. Do we have to wait a half an hour or 35 minutes or 60 minutes for the onset, or is it as quick as 3 or 4 minutes? What is the duration of this drug? Can it be titrated if it's IV? If so, how long does that take? What about antagonistic drugs to our sedation regimen? How long does it take for those drugs to take effect, particularly if the patient is going downhill? How long does it take for that to happen? What can we expect? How soon thereafter can we add a second dose of that same drug? So that's really important. And what effects does it have? We know that there are ways that we can affect respiration by adding some portions of an antagonistic drug, and if we really want to have all the effects of the drug diminished, then we need to add a larger dose. It's important to make that distinguishment. And reversal agent, know and have current ampules on hand that can reverse a patient that we plan to sedate. Drugs that we use is nitrous oxide. We know we can blow that away with oxygen. For chlorohydrate, which was used for many years, is an excellent drug for sedating children, was used in dental offices in the medical setting. We know that it quickly puts children to sleep and has a duration of about 60 to 90 minutes. Unfortunately, it has no antagonist. And so once we've given that patient that drug, then that's the way it's going to be. It's not a way that we can mitigate how it affects the patient. Diazepam is a benzo, and this benzo is used very often for tranquilization of patients, but also know that it has a longer duration, and it's more typically used for teenagers rather than smaller children. Midazolam is a drug that's very popular now in the dental community. It's very short-acting. Its onset is 10 to 20 minutes, and once that comes on board, it has anterior-grade amnesia, and the beauty of this is that the patient will not remember what's happening or what has happened to them, although the recovery period of that is somewhat discouraging because it tends to cause the patient to be a little more obstreperous when they come out of their sedation. Hydroxyzine is a very lightly sedated patient. It's an antihistamine, which when put in combination with meperidine is a great drug to use to help reduce the opportunity for allergic reactions. Meperidine is a drug that we also use, and this is an opioid which tends to cause the patient to have obtunded muscular activity as well as physiologic obtunding. And on top of this, we have used multiple drugs in combination. Drugs such as meperidine and midazolam, or meperidine and hydroxyzine, or meperidine, hydroxyzine, and chlorohydrate, or nitrous oxide with meperidine, diazepam with chlorohydrate. So these are the kinds of combinations that put a patient in a higher risk category that we must be understanding and ready for our sedation episode. Monitoring airway, head position, respiratory sounds, those are all important for us to maintain a patent airway so that airway exchange can occur and ventilation is appropriate. The cardiovascular system with the heart rate and the blood pressure linked as they are, it's important to watch and see what is happening when we look at the heart rate and the blood pressure. Is it something that really needs to be monitored carefully? And we think that it does, because it affects how the patient's going to react and what sort of quality experience that they have with sedation. The respiratory system is the area where we can have the greatest influence from a preventive standpoint. We need to see reservoir bag movement, patient color, pulse oximetry, capnography, and pretracheal stethoscope. And we're making constant observations on how the patient is responding to the sedation. But knowing in advance that we can control our local anesthetic dosage, we can control our sedation drug dosage, it's really important to know that we can avoid a lot of adverse sedation events by being careful with our diagnosis and ensuring that the local anesthetic and its capacity to change the physiology of the patient is carefully monitored with regards to its addition to a sedation regimen and the combination of the sedation drugs and the local anesthetic, producing a problem in the respiratory system that may be difficult for us to handle. Documentation of what we do is very important. It's a medical legal necessity. It's a record of how we handle the patient, and it's a way to protect the patient, but also to protect the clinician. It tells exactly if we fall within the standard of care. And if we fall within the standard of care and have responsibly developed the dosage levels for our sedation drugs and provided those to our patient, that we are working within a reasonable level of certainty that those other practitioners in our specialty would be doing the same thing under the same type of circumstances that we're using for that. This medical legal document is a document that goes with the patient and it stays with the office so that further treatments with the medication may be handled as appropriately or perhaps even more appropriately than it was first done. Pre-sedation must be written instructions, written in such a way that the patient and parent and guardian understand exactly what it means when we say a treatment plan. If we say an MOD composite, are we telling the patient anything? So we must say clearly we have an aesthetic restoration, an aesthetic filling that's going in the tooth, and it's going to look really good when we're finished, and it's going to be the appropriate treatment recommended for this disease condition that your patient has. Informed consent, you need to have a pre-treatment history, and it must be included in the record, and it's important to have this informed consent in the pre-treatment history based upon this informed consent, because we want to use the most current information when we're getting ready to do this sedation. The current weight, what the weight is this patient pre-hypertensive? Are they hypertensive? Is this patient below average weight? What are the baseline vitals for respiratory rate and heart rate and all the other baseline vitals that are necessary to make sure that this patient is going to be all right? Intraoperative time-based record of vitals, no longer than 10 minutes. We need to have a recording of the vitals during the sedation treatment, the route and the dose and the time of administration. In addition to that, should an urgent situation arise, it's important to have that sedation record going so that whoever's recording the information will be able to record exactly what precipitated the urgent event and also to record the medications that were being used to resuscitate and take care of that patient under the urgent situation. The patient's condition at discharge may include vitals and the time of discharge. It all needs to be recorded that this patient met all the discharge criteria, and the postoperative instructions were given in written and verbal form so that the patient can leave the area of sedation in as excellent condition as we can provide. This also includes the nitrous oxide and oxygen levels. Did we deliver 60% nitrous and 40% oxygen? Did the patient do well with this kind of combination? What was the duration of the use of nitrous oxide? Was it 5 minutes? Was it 10 minutes? Was it 30 minutes? And that we recovered the patient with 5 minutes of 100% oxygen when the patient left the operatory. All these are criteria for discharge from the operatory, and including in monitoring the patients in their documentation. Discharge criteria is a way to evaluate the physiologic status of the patient as they're leaving the office. Are the vital signs within the normal range? Is the airway stable? There's no nausea, no fever, no potential for vomiting when this occurs. The postoperative instructions have asked for the patient to be monitored carefully once they get home for the remainder of that day, to have clear liquids when they get ready to go home if that's appropriate, or a light meal when they get home, progressing to regular as needed. Is the patient oriented to the surroundings? Do they recognize their guardian? Do they look confused? Do they look as though they don't know what's happening to them? Can they walk, talk? Can they support their head? Are they well hydrated? Postoperative instructions are going to be in writing. The guardian is available. The documentation of recovery status is critical. A numerical scoring system to assess discharge criteria provides an objective measure of readiness for discharge. And examples of discharge criteria is the Aldrate discharge criteria, developed in 1995. The Steward Simplified Post-Anesthetic Recovery Scale, developed in 1975. So it's important to use something that is objective criteria that tells us that the patient is recovered and recovered well and ready to adjust at home. Physiologic monitor notes based upon behavior is available in the AAPD Handbook of 2018. We want to know the behavior of the child. Was the child screaming or yelling? Any vocalizations? Was there mild crying? Was the patient quiet? Was the patient quiet and unresponsive? And then there are clinical signs and precordial signs and capnographic signs and pulse oximeter signs that can be utilized from this monitor notes that enables us to characterize the behavior of the patient, the objective criteria that's delivered by the precordial, capnographic, pulse oximeter information, and the clinical signs that we're seeing. Is this patient recovering well? Are they responsive or not responsive? So it's important that these monitors are apparent and in the medical record and dental record of the patient that's had the treatment done. What is the evaluation of a deteriorating patient? How do we know when a patient is having trouble? Well, first of all, the system that we concentrate on the most highly, and that's the respiratory rate. Is it depressed or arrested? Is there a problem with ventilatory or oxygenation in nature? Is the child using chest breathing, non-diaphragmatic, which would suggest respiratory distress? Or is the diaphragm being used? Is there seesaw respirations going on? And so as we look at that and make a determination, is there nasal flaring going on? Is there platysma flaring? Is there grunting going on, suggesting a lower airway obstruction or inability to exchange oxygen and carbon dioxide? Is there rocking horse, seesaw respiratory pattern? Are using intercostal muscles for breathing? Is the upper airway obstructed, including laryngospasm? So if we see in a patient, we'll know that the color is going to be changing, that the breathing pattern is going to be changing, and we need to change with it to provide information and drug therapy that will help this patient to recover from their sedation. What about allergic reactions or overdoses? If there's overdose, we're concerned by the lack of responsiveness of the patient. Are they cognitively aware? Do they respond to a light tactile stimulation, or do they require painful stimulation to get a reaction to them? If there's an allergic reaction, we're looking at maybe hives or some rashes beginning to develop, some angioneurotic edema which may be developing. And if so, we need to have the capability of giving Benadryl, oxygen, epinephrine, and many medications that are going to help this patient to recover. If there's more than one organ system involved, for example, the respiratory plus dermatology, then we need to offer this patient some albuterol, and if we see the dermatological addition to our respiratory issues, then we know that the patient is having a anaphylactic reaction rather than an allergic reaction. What about bradycardia and or hypotension? Hypotension can be caused by patients that are inadequately hydrated and may have overextended their NPO status so that the patient has been dehydrated for more than 10 or 12 hours. Bradycardia is when the heart slows down due to sedative action, and it's important for us to provide some atropine to improve that heart rate so the patient is going to be able to recover from the hypertension and also the blood pressure to a more normal level. Is the patient hypoglycemic? Ensure that glucose preoperatively, if concerned from a diabetic. Have they had some source of glucose to begin with, orange juice or frosting? Is having that on hand? Is vomiting occurring? Because the right main stem bronchus is straight, it's more likely to be affected than the left main stem and more likely to aspirate. And seizures. Is the patient having a seizure? Is a seizure related to overdose of local anesthetic, or is a seizure related to the patients having some seizures in their medical history? So it's important for us to know that those things go on. Here is a case study we'd like to talk about here just for a few minutes that will show us exactly the kind of things that can happen with a patient. This is a 3-year-old, 3-month Caucasian female, presents with a chief complaint of pain on the upper left. A review of the medical history reveals a patient with mild asthma control with albuterol inhaler as needed. The patient's dental history indicates that she had a dental visit about a year ago, but due to uncooperative behavior, she was dismissed and it was said nothing could be done. Her social history states that she has a 7-year-old sister without her associated severe early childhood caries. Upon examination, she was resistant to open her mouth in a knee-to-knee posture, and the mother employed active protective stabilization by holding her legs by her elbows and her hands held. The patient refused to open her mouth and used a scissors grasp, and using a scissors grasp, she had it open and a small McKesson mouth prop was inserted for examination. The screening exam revealed teeth number D, E, F, and G were destroyed to the gum line with no evidence of perilous abscess or teeth, and tooth number B and I had gross coronal tooth decay to the gingival margin. The patient was not taking any medications for pain nor infection, and the review of systems indicates the patient is in generally good health except for the asthmatic symptoms seasonally. Because of the resistance exhibited, it was determined to take oral photos, if possible, and sedate the child by immediate removal of the anterior incisors, application of STF on teeth B and I, and wait or monitor for future treatment after the extractions. The patient was sent to her primary care provider with a consultation with date, name, date of birth, and photos. The referring doctor's treatment plan and expected date of treatment was provided, and the request for clearance for asthmatic condition and sedation with midazolam. The accompanying photos were sent for justification for sedation. The patient was scheduled for sedation after receipt of clearance from the MD. The preoperative sedation checklist was used to prepare the facility for the treatment. Consent was obtained from the mother at the scheduling time, and she was counseled verbally and in writing regarding the risks, procedures, benefits, and complications regarding the treatment. On the day of the treatment, a review and update of the medical history, review of the medical consult, review of the consent, any further questions were conducted. NPO instructions were followed. The patient had their albuterol inhaler with her, and a third party was available for transport of the patient home. This is a view of the patient, and this is the initial evaluation of the patient that we were able to receive due to the patient's lack of cooperation. The maxillary incisors were decayed off to the gingival line, and the mandibular incisors were the only intact teeth available in this view. It was determined that no medical history nor additional medical changes were made. An inspection of the oral cavity was made to determine the Mallampati score, which was number 2, and the Brodsky evaluation of the tonsils, also number 2, and the patient's weight and height were taken, and she was found to be 5.4 kilos and 37 inches tall. The measured dosage of the midazolam was 7.7 milligrams, or 0.5 milligrams per kilo. Oral liquid was measured along with flavoring from liquid acetaminophen, 3 milliliters of strawberry acetaminophen, for the patient to swallow. The maximum dosage of local anesthetic was calculated at 4.4 milligrams per kilo, or 3.7 corpules of lidocaine 2%, 1/100,000 epinephrine, and 0.017 milligrams of epi per corpule. The reversal agent, flumazenil, was calculated at 0.01 milligrams per kilogram, or 0.015 milligrams, and prepared in readiness. The room was prepared after verifying the O2 N2O tanks were full and functional for the procedure. The emergency room cart was current with medications. The assistants were present, one for chairside and the other for recording the sedation record. Initials were provided on the document by the doctor and the assistant regarding the treatment plan and a review of the recent changes and consents. The patient was brought to the operatory with the mother and dressed in loose clothing. NPO status was confirmed, and the mother was instructed to hold the child while the oral medication was delivered by the syringe orally in a semi-recumbent position, facing the doctor, while the mother prompted her to open her mouth. After a few moments, the patient complied and took the medication. The patient was introduced to the pulse oximeter and papoose board. TV distraction was used overhead, and the patient was monitored for 30 minutes. At the end of 30 minutes, the patient was drowsy and placed in a stabilization device, ensuring was not impairing her breathing. A foot was protruding from the end of the covering for placement of the pulse oximeter on the large toe. The blood pressure cuff was placed. TV distraction was in use, and nitrous was placed via nasal prongs attached with a capnography tubes for monitoring the carbon dioxide end tidal. The patient was given 100% oxygen for 5 minutes, then titrated from 30% to 50% over a period of 10 minutes. A topical anesthetic of 20% benzocaine was rubbed on the gingival tissue adjacent to teeth D, E, F, and G, and a folded 2x2 was placed to absorb any secretion from the topical application. After 2 minutes, the sleepy patient was given 1.5 corpules of lidocaine, 2%, 1/100,000 epinephrine, 0.017 milligrams of epi, as a treatment planned, and the child was monitored for signs of nitrous sedation, midazolam, and local anesthesia. At the beginning of the treatment, using a 301 elevator, the patient was simulated and discomfort was elicited when the palatal tissue was compressed. The patient was giving a gingival infiltration adjacent to teeth number D through G. The patient cried, but little movement was noted. 1 minute later, using the elevator in 1/54 steps, the teeth D, E, F, and G were removed without complication. The patient continued to remain quiet. Bleeding was controlled, and the patient continued to be monitored for O2 sat and CO2 exhalation. When things go wrong, the following things can happen. It was noted during the recovery period that the capnography began to show readings that indicated hypoventilation and an increased level of 48%. The nitrous was off and she was receiving 100% O2. The CO2 reading was creeping up and the color of the patient's lips, oral mucosa, perioral area was beginning to look pale to darkish. This indicates hypercarbia and ventilation is not occurring. The waveform begins to look like a shark fin. The patient's posture is elevated with accompanying chin lift. The shark fin continues to slope and the breathing remains at 48 millimeters of mercury. The patient is given her inhaler for 8 to 10 puffs and leaned forward in a tripod position and monitoring continues. The operator prepares for intubation or bag valve mask use, and the jaw thrust was employed and 100% positive air pressure was administered using a bag valve mask device. The carbon dioxide reading dropped and improved, and the operator prepares for reversal of the midazolam, application of positive pressure oxygen, and possible intubation using an LMA or a laryngeal mask airway. When reversing midazolam, one must think that prolonged monitoring must take place because the reversal agent has a half-life shorter than the sedative agent. Therefore, in this case, one must be prepared for resedation. Contacting EMS would be a prudent choice for this patient. The reversal drug doses of flumazenil is 0.01 milligrams per kilo IV every minute for 4 redoses not to exceed 0.05 milligrams per kilo. Observe for improvement for a minimum of 2 hours minimum. Vials of 0.04 milligrams per milliliter can be diluted by adding 3 milliliters of saline, making it a strength of 0.01 milligrams per milliliter. After reversal of the drug, the patient was supported with 100% oxygen. The patient was kept a couple of hours in recovery, and the healing of the anterior alveolus was completed in the next 3 months. Hypoxia, when prolonged, can affect the cardiovascular system and lead to rhythm changes. Quick responses to hypoxia can avoid the concerns with cardiac sequelae. What if the hypoxia caused a change to a rhythm? Narcotic overdose can result in cardiac arrhythmias as well as respiratory depression, resulting in emergent life-threatening conditions. One must be trained to handle these emergencies and call 911. If you need clarification of any of this information, please send an email to pace@uth.tmc.edu. Much of this information was taken from the AAPD Handbook on Pediatric Dentistry, and references as well as that one can be used to prepare yourself for sedation treatments and to be on the watch and look out for sedation emergent conditions. It's important to have a system in place and to understand what it takes to get yourself back on the road to health when a patient has a misadventure. It's important to realize that the respiratory system is really key to moving on to other systems. We have good preventive activities that can be formulated, and if we can control the ventilation of the patient and the ability to exchange oxygen, then we have this patient well under control, and that consequences going towards the cardiovascular system can be reduced or eliminated. Reading these references will help you to understand the rationale behind the course that you have just taken, and that this information is there for your taking. It's allowing you to learn more and be much more detail-oriented in learning about anesthesia than you may have had the opportunity to do before. Take the time to do that, and you will become the bearer of good quality sedation that is safe and allows your risk levels to decrease significantly. Sedation is not without risk, but requires attention to detail in your ability to be able to resuscitate a patient who's gone into the next level that may be deleterious to their continued health and neurological status.
This completes the sections of the course. It's time for you to take a short exam in order to complete the requirements for streaming video courses. And once you have completed that, the nature of the subject, you need to get a passing score of 80%. It's necessary in order for you to advance to the next section. Upon a successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you'll be instructed to take the exam, and a new set of questions will be provided. You'll have 3 chances to fulfill the requirements. If you're not successful, you'll be instructed to review this section again. Good luck on the exam.
Thank you for taking this course. It's been a pleasure to be able to develop this for you, and I'm hoping that you will have a successful sedation regimen developed within your office that is clearly one of the superlative programs in your area. Have a great day, and thank you so much for taking this course.